Hi, Gwen. Why does it say I'm Gwyneth Lee?
Hello. Not sure
Hi,
why there are two of
it's
me.
Sarah. I, I don't, when I joined, like it said my name was Gwyneth. Let me try
I think I must have set up the Zoom the way that I set up the Zoom link.
rename.
I'm going to rename you, or do you want to rename
Yeah.
yourself?
Yeah. Yeah. So will everyone who joins be Gwen?
Good question. I do hope not, because that would be a bit confusing, but
Yeah, I don't think, I mean, I'm assuming it's really just probably our group.
I think so. I mean, I did send out an announcement, or it was sent out, but I feel like especially at this point in the semester, it's pretty hard to
Yeah.
round people up, which,
The I did get a lot of emails from the Cancer Center. All those folks saw it,
oh,
but
great.
they have a like retreat or
Uh,
like a whole day like workshop today,
mm.
um, which I normally would have been at. And I was like, because when I responded, everyone was like, "Oh, I can't make it. I'll be at the retreat."
So, thank you all for coming. Very pleased to be introducing Tara and Harry today. I'm really looking forward to this presentation. So, the brief introductions are that Dr. Friebel-Klingner is a cancer epidemiologist specializing in global oncology and implementation science, with a focus on prevention, detection, and treatment of breast and cervical cancers in sub-Saharan Africa. And really looking forward to her talk today. Maybe we can invite her back next year to hear about exciting new work that I know she's starting up as well. And Dr. Harry Iyer is an assistant professor at the Rutgers Cancer Institute, as well as director of the Geospatial Data Hub and the Rutgers Center for Climate Health and Health Care. And his research investigates how neighborhood and environmental factors influence risk and progression of prostate cancer, particularly in high-risk populations, such as Black and African American men. So we're really looking forward to their joint seminar today about leveraging geospatial analysis for cancer control in sub-Saharan Africa and geospatial data science training for African cancer researchers. So take it away.
Great. Thank you so much. Thanks so much for inviting us. And so we can share, the information that we're learning about geospatial analysis for cancer control in sub-Saharan Africa. So our talk will be, I'm going to start and I'm going to talk about some work that we're doing in an analysis that we are hoping to publish soon, looking at geospatial analysis for breast cancer specifically in Tanzania. I'll talk about the background, a little bit about the geographic information system, methods and tools that we've been using, the methods, and then I'll talk about the results. And then Dr. Hari Iyer will talk about geospatial data science training for African cancer researchers. Dr. Iyer and I met in, I think it was 2018. I was doing my dissertation work and I wanted to include geospatial analysis. So I was introduced to him and he's been my mentor ever since. He's one of the best teachers I think I've ever met. And he really helped me along. And so ever since then, we've kind of been working together on geospatial and cancer control in sub-Saharan Africa. And we co-taught a course in Tunisia last November that he'll talk about as well. So that was a great experience for me, and happy to be presenting the work that we're doing. So. As I mentioned, I'm going to talk about our analysis of breast cancer patients presenting to Bugando Medical Center in Mwanza, Tanzania. Tanzania is a country in sub-Saharan Africa. It's on the east coast and it's just below Kenya. It's a beautiful, beautiful country I've had the privilege of visiting a few times now. It's a lower middle income country, about 73 million people. The capital is Dodoma and it has a tiered health system from dispensaries to clinics to a number of different hospitals, district, regional, zonal, and national being the top tier of the health system. There are three hospitals in Tanzania that offer oncology care. And this is one of the main reasons, we're looking at geospatial analysis because knowing what I just said, that there's 73 million people in Tanzania, yet there's only three hospitals that offer oncology care brings access to, patients getting care as an issue. So these are, things we're looking into to try to improve access. But the three hospitals that offer oncology care include Ocean Road Cancer Institute, which is in Dar es Salaam, Kilimanjaro Christian Medical Center, and then Bugando Medical Center. And this is in the northern region on Lake Victoria. And um, it's a public facility. It's one of the three public hospitals. They also have private facilities. Um, they do not have universal health care in Tanzania. I'd say about 50% of our population does have health insurance, and then the other is paid out of pocket. So our study takes place at Bugando Medical Center, as I mentioned, in the northern region. It's a zonal referral hospital. It has a catchment area of over 20 million people. So it's comprised of 8 districts, made up of 52 sub-districts. And so that's the catchment area for Bugando Medical Center. And they offer oncology services, including chemotherapy, radiotherapy, brachytherapy, and surgical oncology. So Bugando Cancer Center, actually, they just built this cancer center on the campus of the medical center. And it's a beautiful new hospital that I visited in 2023. And so a little bit of background on breast cancer in Tanzania. It is the second leading cause of cancer deaths in women, followed by cervical cancer. The screening rates are very low. About 3% of women have reported undergoing breast cancer screening. The Most cases are presented late, so over 65% of women are diagnosed with advanced stage 2 or 3 breast cancers, and the survival is very low, so it's less than 25% 5-year survival rate. And this is reflective of global inequities of breast cancer. So high-income countries like the United States, about 9 out of 10 women survive when diagnosed with breast cancer. South Africa, which is actually doing a little better than Tanzania, about 40% survive. So this global disparity is an increasing concern. And then cases are also projected to increase by 82%, with an 80% rise in deaths expected by 2030. So this is a large problem that's only getting worse. Part of this issue is attributed to low knowledge and awareness of breast cancer among the communities, barriers in accessing health services. As I mentioned, it's a large catchment area with few centers that offer care, and then there's a scarcity of resources for optimal treatment. Specifically, in 2017, Tanzania did a breast healthcare assessment. This was done with Susan G. Komen in collaboration with the Ministry of Health. And we can see there was very little data at the time. There is still scarcity of data, but what they had reported for their national report was on 29 women with breast cancer from 14 institutions. But the statistics show that the time between the first symptoms and seeking care was 1.8 years. There was a system delay of almost 8 months from the time to see a doctor to providing appropriate care. And so these all compound the issues that we have. And as I mentioned, the out-of-pocket prices are very costly. And in this report, 7 out of 29 people had health insurance and 22 did not. So in response to this, Dr. Ann Rossich, who was my postdoctoral mentor at Johns Hopkins, she started this Time to Act study. It was a co-creation, implementation, and evaluation of a multi-component clinical breast cancer intervention. This was a provider level intervention that was focused on improving diagnostic breast cancer pathways. And it was at Bugando Medical Center. And we prospectively followed patients through BMC's medical system from 2019 to 2023. And while that study is now wrapped up, we're looking at additional ways to help improve breast cancer care in Tanzania, which brings us to the geospatial analysis. And so we're asking, how can we make access to breast cancer services at BMC equitable for this large geographic catchment area? And so we want to understand access to cancer services in the area and then potentially think about decentralizing breast cancer services or the breast cancer intervention from the Time to Act study to regional and district hospitals. So a little bit about geospatial analysis for cancer control. Some of the main things that this can do for us is we map cancer burden and inequities, so we can identify geographic patterns in cancer incidence, mortality across regions and populations. We can get insight into accessing cancer services by measuring distance, travel time, geographic barriers to screening, diagnosis, and treatment. It helps identify care deserts, where places have inequitable access. And so those are what we will be focusing on. And then understanding those aspects can lead us to potentially targeting and planning early detection and screening programs. Then we would evaluate the implementation of these, all to inform policy, resource allocation, and equity-focused decisions. So a little bit about geographic information systems and spatial statistics. So geography can pose a significant obstacle to healthcare access, particularly in this country. Geographic information systems, they offer a robust analytic approach for evaluating the spatial relationship between spatial context and health outcomes. Geographic information systems can integrate diverse geographic data sources, many of them public, which is a great, I think, attribute of using geographic information systems because there's a lot of information that we can, kind of compile to, look at certain questions and answers. And then spatial statistics, which I'll be reporting on. These are statistics that can define the spatial relationships between geographic units. It can quantify these relationships, and then it can help us understand if the patterns we are seeing are strong enough that they couldn't happen by random chance, and maybe potential insight into why they're happening. So the spatial statistics that I'll report on that are most commonly used are called the global Moran's-I. And then there's also the local indicators of spatial autocorrelation, or LISA. And these tests estimate spatial autocorrelation across different geographic areas. So the global Moran's-I, as it says, can kind of estimate the spatial autocorrelation across the geographic region. So overall, what does it look like? And then the LISA helps us kind of zoom in on specific units of analysis, which in our case are subdistricts, that may have some clustering or dispersion. So for our geospatial analysis of breast cancer patients, we aim to identify areas of limited access to breast cancer care. So we're going to do this by determining the spatial correlation, or the Moran's-I, of the breast cancer cases that are presenting to Bugando Medical Center. And then we'll identify if and where breast cancer patients disproportionately present to Bugando Medical Center for care, and then also look at the community level characteristics associated with subdistricts where the breast cancer patients live. So our study population included women over the age of 20, with breast concerns presenting to Bugando Medical Center between 2019 and 2023 that were subsequently diagnosed with breast cancer. So these women were from the Time to Act study that I mentioned that Dr. Rosich ran. The breast cancer cases were geocoded to their subdistrict of residence that we extracted from their medical records. And then the unit of analysis we are going to look at is the 52 administrative subdistricts that represent the catchment area for BMC. And then our age standardized breast cancer presentation rate will be calculated for each subdistrict. And so this is the unit of analysis we will look at. It's standardized to Tanzania's overall female population distribution, and we calculated it by using the number of breast cancer cases that were diagnosed at BMC over per 100,000 females for each subdistrict over the age of 20. The community level factors that I mentioned that we can, combine a bunch of different using public databases, combine different information. We're looking at travel distance. So from the centroid of each subdistrict, how long, what is the distance in kilometers to BMC? And we can see that some of them are over, 400 kilometers away. the population density, so looking at urban versus rural areas, and then we also map the health facilities. So we're looking at district and regional hospitals that are in the different subdistricts to kind of inform us about the community level factors. And then, as I mentioned, for the geospatial analysis, we use the global Moran's eye, and the results of the global Moran's eye will tell us if the distribution of the cancer cases we were seeing, if there's a random or if there's a positive or negative global association. And so, if it's not significant, it would be random. Positive or negative global association would tell us that this is not happening by chance alone. I have here that we're using the Queen's continuity matrix with 999 permutation tests. That's kind of detailed. And so when Hari and I co-teach these courses, or we co-taught this course in Tanzania and the other courses that he has, we go into how these are calculated and why we use certain continuity matrices and the number of tests and things like that. And then we'll also look at the LISA, and the LISA will show us if any of these subdistricts are part of clusters, meaning like the subdistrict has a low presentation rate surrounded by other subdistricts with low presentation rates, or if it's a high cluster, meaning the subdistrict has a high rate surrounded by districts with similar high rates, or if they're outliers, meaning a subdistrict may have a high rate surrounded by subdistricts that all have low rates. And then we'll also do a statistical analysis looking at the community level factors. And so that will be ordinary least squares regression with a spatial weights matrix. And so this is our cohort. We had 381 breast cancer patients that were diagnosed. The median age was 51 years. About 46% of them have insurance. 65% were diagnosed with late stage. Distance was on average for the patients 180 kilometers. Almost half the population was lost to follow-up before treatment began, or sorry, before treatment was completed. And what else? About half the subdistricts do have a referral hospital in them, and we saw about 80 to 90 patients per year. Our study started in August 2019, so that's why 2019 is pretty low, but I think it was a pretty steady 80 to 90 patients per year we're presenting. And then for our characteristics of our subdistricts, the units of analysis that we used, there were 51 of those that were included. And there were 52 subdistricts, but if you can see, there's this one island that doesn't share borders with any of its neighbors. And so that was not included in the analysis because it can't be calculated using the Moran's eye. So that was removed. And so we were left with the 51 subdistricts. There was a mean average of 8 cases per subdistrict. There was a mean of a 4.0 presentation rate per 100,000 women for each subdistrict. From the centroid of the subdistricts to BMC was approximately 280 kilometers on average. And the density, and then 39 subdistricts had a district hospital, and only 15 of the subdistricts had a regional referral hospital. And then the breast cancer presentation rates per subdistrict in the catchment area, we can see, if we're looking at it directly, we can see that the rates are higher, for the subdistricts that are closer to BMC, and then it kind of tapers off as they get further away, with some exceptions. But we can see in this figure, this is a chloropleth map of the presentation rates across the Bogando catchment area, and there are a number of subdistricts that had less than one patient from each, and then only a few that had about 15 presentation rate of 15 or higher. And so when we applied the global Moran's eye, these are the results that we're seeing. And so it looks at the subdistricts that have low rates surrounded by low rates, and those with high rates surrounded by high rates. And the global Moran's eye was significant and it was 0.29. And so this is showing that it's significant and it's positive. So it's kind of indicating that there's clustering of these rates and it's not random. And when we want to look at the regression analysis, when we want to put in the distance, the population density, and the regional hospitals, we can see that all these are significant as well. So the distance we can see was significant. And so all these individual factors are significant. And when we put them in with a spatial weights matrix that we get from after we've done the global Moranzi, when we adjust with the spatial weights matrix, the p-value, oh sorry, the p-value becomes 0.157, and so it's no longer significant. So what that is telling us is that the global Ramsay is showing that there is clustering, and it is significant, but when we include these factors in the regression analysis, the distance, the population density, and the regional hospitals, those are accounting for the clustering and the significance. And so when we include them all with the spatial weights matrix, it is no longer significant. So that is indicating that these factors are what's responsible for the clustering. And then the global Moranzi, if we look at this scatter plot, we can see, all these circles represent one of the subdistricts. And so the circle colors, these represent the local Moranzi. So they're actually telling us each subdistrict if they have how they're related. And so the Lisa looks at can tell us which of these subdistricts actually are significant or potentially causing the clustering that we're seeing. And so we have two low clusters. So these were two subdistricts that had low rates surrounded by other places with low rates. We have three high clustered subdistricts. It's no surprise that those are the subdistricts that are closest to Bogando Medical Center. And then we have this one high-low outlier subdistrict. And so this one it has a higher breast cancer presentation rate, but it's surrounded by other subdistricts that have low rates. And so we want to kind of look at the difference between these, where it's disproportionate access, we can think about it, because it's where the women are presenting from. This can kind of give us some insight into why potentially women are presenting differently from these different areas. We can see from the high area, it's a 16.4 presentation rate, which is much higher than the other sub-districts. The distance from the high area, as we saw, is much shorter. The other distances are much higher. And then the regional referral hospital, the low subdistricts do not have any regional referral hospitals in their subdistricts, but the high subdistrict does have one. So we see that, the representation of the regional referral hospital could indicate why there's more access. And so in conclusion, our global Moranzi results did reveal significant spatial clustering of presentation rates, but the observed spatial patterns are largely explained by population density, regional referral hospitals, and travel distance. The LISA results revealed that there are specific clusters and outliers of certain subdistricts. We saw three high, two low, and one high-low. So across clusters and outliers, we saw difference in distances and having a regional hospital. And so what we can learn from this is it gives us potential insight into why people are presenting disproportionately to Bugando. So potentially barriers are burdensome travel distance, lack of a regional hospital, and then low population density, so rural areas. So we take this information for our next steps. We could then go and investigate these subdistricts with disproportionate presentation rates and try to understand more, what's happening in these certain areas. We can adapt and scale up our breast cancer care interventions to additional sites. We could focus on the, low subdistricts first to try to increase the numbers coming from there. And then this evidence can inform trends and policy. So that's the talk that I'm giving, and then Hari can maybe explain a little bit more about geographic information systems.
Yeah. Thanks, Tara. That was a really nice talk. I see that there's like a couple of comments, and because our talks are quite different, maybe we can pause and you can do your questions now, and then I can do at the end because they're a little bit different. What do you think? Should we do your Q&A now?
Yeah, sorry, I was trying to turn my volume off. Okay. Yeah, I see a question. Could be sample size? No. Um, so the, so the sample size, so that's why that we did the presentation rate. So we looked at the number of cases per the population. And so we standardized that to the Tanzania age distribution. So we were hoping that, that accounts for the different sample sizes and the different populations. Um, so that's why we were
Yeah,
looking at.
no, my question was because when you did the permutation, nothing continuous significant, and then I don't know if you have like a population and you compare only with 200 cases that you split in groups in different groups, and then was my question. Maybe when you corrected for all the all your analysis, you lose the significance. This is what I worry, but I don't know. This is something.
Yeah,
Are you
no,
plan to increase the sample or maybe, decide any other variables that, because, as I understood, you follow all, you decide to analyze everything because this is like is a driving hypothesis that you try to see all the variables that can appear, but I don't know if will be problematic or not because the population, your base is a your variable is much higher than this 300. No, when you compare, this is I didn't understand. Sorry, but was like a because
sorry. Yeah,
you need to have like a lot of data to do geospatial analysis and correct it for all these permutations. And I don't know how many variables you use or how you split your sample size. That for me was a question.
yeah, no, thank you very much. No, I appreciate that. And unfortunately, I feel like and I apologize, my microphone was muted for a second there, so I didn't hear you talking right away. So my apologies if I was talking over you. I did not mean to. Um, but So yeah, so I mean, in these sub-Saharan African countries, our sample sizes are small. These are the breast cancer cases that have presented to Bugando from this entire catchment area, and it's very few. We do expect that there are more breast cancer cases out there, but they're not presenting for care. And in Tanzania, it's unlikely they're going other places for care. As I mentioned, there's only Bugando Medical Center is the only hospital in the catchment area that can provide oncology services. So we have limitations. We have to work with the small numbers that we have. We did try to standardize it, but I do agree with you. Some of the sub-districts had zero cases come from them at all. And so, looking at these analysis are just exploratory, but then moving into these sub-districts to potentially try to understand where more cases are coming from, and understanding the places where cases are not coming from. Because I think that's like sort of the main concern is that, there are a number of sub-districts where nobody is presenting from. And
Yes.
this is not looking at incidence or biology necessarily, it's looking at access. And so we're not saying that there are no breast cancer cases there. We're just saying that they're not accessing medical care. And that's really what our focus is trying to understand, how they're accessing care. And if they're not, how we can, help improve them to access care. But again, it is limited to the women who have shown up at the tertiary hospital that we are working at. And hopefully we can, expand this and spread out and understand, cases closer to home.
Yeah, no, congratulations is fantastic. I agree with you. It's just like a comment to try to see when you do like the statistic analysis, if you need to like take account all this environment and the samples and maybe decide something or decrease the permutation, something like that. But
Yeah,
thank you.
yeah, and we have done it. We have run it a number of different ways. That's one of the nice things, you can rerun it with different permutations. We didn't get dramatically different answers, even doing different continuity matrices. So yeah, it's just the numbers are small.
Tara, I see that Dr.
Oh,
Diarra has his hand up.
yeah.
Thank you, and very informative, presentation. I got a few questions, but the main one is, how is government involved in all of that? And the analysis is providing very useful information, but how does this inform their actions or their plans?
So that's a very important question. Thank you for asking it. The government is pretty involved in Tanzania. So one of the things we have worked with the government is they don't have universal health care, but cancer patients are supposed to receive services for free. So once you are diagnosed with breast cancer, you should be able to, get all the treatments covered without health insurance. And so one of the things we've worked with the hospital and communicating with the government is, there are breast cancer, they can look at it and say like, oh, we don't have any breast cancer patients if they weren't diagnosed. But we're helping try to inform with numbers and epidemiology that no, we have about 100 breast cancer patients a year. We need to provide, treatments and chemotherapies and these services and make sure that chemotherapies are in stock. So it's kind of just using the data to show that, these cases do exist and we need to have treatments available for them. And also, our intervention was at the tertiary hospital because we didn't want patients entering a broken system. So now that the system for referrals and diagnosis has kind of been improved, and the doctors are very good at clinical breast exams and referring patients, to oncology services, that we're expecting, more breast cancer patients to come, and then we will communicate, that we need more services, more chemotherapies provided, and things like that for the patients, if that makes sense.
Thank you.
Yes.
Great. Maybe I'll take over now. And my part of
Yeah,
the talk is quite a bit shorter. And I'm gonna try, let's see if technology will be on our side. Tara, I'm gonna try to control your screen so that I can advance.
okay.
Let's see if this works.
I can also do it for you.
That's okay. Yeah, I think this might just oh,
Oh,
I think I tried to do did I just close the entire thing? That was not my intention. Oh, there it is. So if you have your slides shared as they were and I click so do you want to put it back in the sort of format you had it? And now if I click request remote control,
oh,
I
okay.
think I think it's gonna let me.
Yes.
Perfect. Okay. Yeah, so thanks everybody and thanks Tara for a very nice talk. It's Tara has given us a nice overview of the reasons why we would pursue studies of geospatial analysis. So I'm going to just move through these a little bit more quickly and talk a little bit about training, geospatial training programs. So just a bit of background about myself. I'm an assistant professor in the Rutgers Cancer Institute, but spent 3.5 years living and working in Zambia and then Rwanda. At the time, I was supporting health services research projects. And so a lot of the topics that Tara was telling us about with respect to access barriers, thinking about allocation of resources in different parts of the country. I was working with nonprofits and academic groups that were really trying to understand that more from an economics and health services perspective. after pursuing doctoral training, I decided to pursue. I got very interested in the environment, and that was actually how I got interested in geospatial analysis for environmental exposure assessment. However, I never fully lost that part of sort of my interest in being able to use these tools to answer questions about resource allocation, and so have both been trying to pursue training opportunities and through collaborations with those colleagues that I made back then, and have had a couple of opportunities to do trainings with African scientists because I think these are very important questions, and the context that many of the healthcare providers are makes it very critical to understand these questions of where patients are coming from, thinking through social support services to overcome a lot of the barriers that they're facing. And so the first, actually, I'm not I'm not advancing the slides right now. Tara, is this something that you're doing on your side or
No, I didn't,
interesting?
I'm not touching them.
Huh. Very interesting. Okay. Well, in any case, I started this work as a doctoral student at Makerere University. As part of my thesis project, I was studying green space, and so developed a 2.5 day workshop there with students and colleagues. Oh yeah, you know what? That's probably what's happening. It probably is auto advancing. Um, let's see how this goes. I'll get through it. So Makerere University, and then as a postdoc at the Harvard School of Public Health, developed a geospatial data science course through Dr. Tim Rebick. Tim Rebick runs a center there that provides a lot of educational offerings, and this was a totally online course, self-paced, 40 hours to completion, that covers some of the topics that Tara and I spoke about. In 2024, through support from the Rutgers Global Health Institute, I had the opportunity to develop a training in collaboration with the University of Ibadan College of Medicine to do a hybrid training of trainers model where we took some of the materials from this geospatial data science for cancer control and prevention and worked with faculty there to develop materials that would be more tailored to their student population. And then those faculty worked with their kind of institutions there, not just the University of Ibadan, but other affiliated nonprofits and organizations to identify students to take this training and then pursue research projects. So that takes us to the Aortic African Organization for Research and Training in Cancer conference in Hammamet in November 2025. Tara and I had this opportunity to take some of the materials that we'd been building on. Tara obviously is an expert in these methods as well. And given that we knew a lot of folks and this seemed like a very good audience, we decided to develop this training building on some of the materials. And so I'll now go into some detail on what those materials were. So the committee was made up of myself, Tara, a colleague, Dr. Dayouf Delu, who's at the Harvard Medical School, is the deputy director of the Center for Global Health Equity at the Dana-Farber Cancer Institute, and then my longtime colleague, Dr. Ike Oluwapu Ajayi, who is the collaborator at University of Ibadan. She's a professor of medicine, chronic disease epidemiologist, and has led a lot of research on infectious disease factors and lifestyle factors in the Nigerian context. As part of this, we wanted to both provide some technical training, but also give attendees the chance to learn from applied research that was happening. And so Dr. Kofi Sutherland and Dr. Peter Kingham have all published really important work in this space on trying to think about how these geographic analyses can help answer questions about resource allocation, understanding how travel barriers might be impacting on patient outcomes for different cancers, and have succeeded in securing some funding for their work. So we reached out to these panelists, and they all very kindly offered to help. I think it was nice for us to get a breadth of institutional expertise, some from the African continent, some from other global oncology research programs that have been very successful in the US. So we broke this training out first by trying to identify some objectives. And so really the goal was to equip students to be able to pursue research like that Tara has presented to us today. So first, understanding just what are some of the key concepts in geographic information systems, provide some opportunities for hands-on guided exercises in geospatial statistical software like R, provide an overview on some of the concepts behind spatial statistical analysis, and then through our panelists, be able to get some exposure to applied research in this space. And so this workshop was a 2.5 day, or sorry, I'm sorry, not 2.5 day, 2 half-day sessions, 3 hours each, with a mix of didactic, practical, and panel presentations. We were also able to get generous support from the Harvard Zoo Center for Global Cancer Prevention and also our very own Rutgers Global Health Institute. So we're very grateful for that support to be able to cover costs associated with this training. For the lecture topics, we wanted to go into some depth on some of the concepts of geographic information systems. While these obviously also rely on computers and software, learning about some of the technical details of coordinate systems and projections and vector and raster data types. We give some examples of that, and we help people orient themselves to some of the terms that are used in this space. Another really important part of the training is to help people interested in this know where they can find these data. And something that I really try to emphasize when I talk about this is these data sets are publicly available and cover pretty much every part of the world. It is really incredible when you look at things like the Google Earth Engine catalog, the OpenStreetMap database, even maps of health care facilities are available, publicly available, do not require you to go out and collect data on your own, do not require you to pay tens of thousands of dollars to somebody. Really, you can just get your hands on these very quickly. And once you develop the skills to be able to work with them, you can answer all kinds of different questions. And then the last piece is to sort of talk through and show how to implement some of the spatial statistical procedures that Tara spoke about and used in her work. Just to give an example of what some of these hands-on trainings look like, there's this really powerful platform called Google Earth Engine that is run by Google, and so they're the kings of search. So they make it very easy to find the different data types you want to look at. They actually have built into their platform the Google Map interface, so you can very easily pan and zoom onto locations of interest. And we show students how to interact with this platform and write JavaScript code to pull different data elements that are relevant to their projects. The other part of our training is to use R and RStudio to learn how to map different geospatial measures that we show people where to find. We're looking here at 2 maps of Nigeria with I want to say these are the ward locations or the sub-district locations, and we showed how to append publicly available measures of a relative wealth index and green space using a satellite-derived measure of green space to those different locations. And you could imagine that if you were conducting a cohort or epidemiologic study in Nigeria, and you had some information about the participants' residence, you could now bring these measures into your data analysis to allow you to answer questions about effect modification by socioeconomic status, or to think about questions related to climate change and vegetation. So what happened when we went and did this? We spent a lot of time trying to identify students before the course started, and we thought, okay, 11, not too bad. Probably were hoping for a bit more, but when we actually showed up, we ended up having 50 unique attendees who came and signed up over the course of those 2 days, which was a really nice. Both demonstrated the interest from that student body, but also was very nice for us to be able to have a larger impact there. Our panelists did a really nice job of covering presentations across some of the topics that Tara discussed, but also thinking about access to cancer diagnostics. And there was really, really great engagement from the students. Lots of really good questions, and attendees from many different countries. So Nigeria, Ghana, and Rwanda were some of the most highly represented, but there were many others there as well, really illustrating that there is a lot of untapped interest in the African global oncology community in learning about these methods and being able to apply them to important questions in their different contexts. So as we think ahead, I think was mentioned. I wear a few hats here, and in my role as the director of the Geospatial Data Hub at our new Rutgers Center for Climate, Health, and Healthcare, we are hoping to start to develop some of these materials here for short courses here at Rutgers, and potentially develop our own online offerings and on-demand videos to show people how to do this. I think with the advent of AI, maybe that's becoming less important because you can look up a lot of this stuff yourself in Claude and ChatGPT and these things. But I think having somebody to be able to talk through, having dedicated time, we're all very busy, to just kind of focus on one thing, I think still has value. We are hoping to follow up with some of the participants of these courses to understand how they're applying these methods, be able to identify collaborations to support research on healthcare access, but also climate change and environmental exposures, and I think there's a lot of really great potential. And so grateful to Tara for accompanying me on this, and to all of our students. And I think I put your Tara's slide at the very end. There's a couple I think on here that are more relevant to the training. But thank you. Thanks for the time.
Thank you so much. That was great, and it's really exciting to see both the research, but also the strong connection to training. I feel like that's such a important strength of our institute, and it's exciting to see how you guys have managed to integrate the two.
Yeah, thank you.
Rick?
I guess I have the same questions that Amadou had overall is what's next for what's happening with interactions with governments and ministries, and they're different depending on where you're at, but are there any take-home messages there of how your trainees or partnerships have influenced policy?
Yeah, I guess Tara, you sort of spoke to this earlier, so maybe I'll jump in here. So I have had work that I've done in the past where through the collaborations I was in at the time, they facilitated those interactions. So when I was at the Dana-Farber Cancer Institute, we had a visiting scholar who was on sabbatical from the NCI who was on a Lancet commission. And I mean, that's like a hyper, that's probably the best way to get plugged in and get to know a lot of ministry folks. And so through that gentleman, John Flanagan, through his kind of support, I got to know some Ministry of Health officials. And so we had developed a methodology to apply the spatial statistical methods that Tara had shown to as a conceptual framework to identify places where if you had resources and were considering building new infrastructure to support diagnostics, the high, low, high, low, those kinds of quadrants, we actually found that those could be very useful for planning to say, oh, if you have high, you don't need to build another facility there. They're doing well. It's the, low high clusters that's where you should probably think about putting your resources. And so through that, we ended up meeting with some officials in the Tanzania Ministry of Health, and we're able to work with them to write a paper that sort of applied that framework. And they actually told us, it's funny that we didn't need your framework, but we are planning to build a facility where your thing is telling us to build it. So it was a little bit backwards, but I think illustrates that sort of thing is possible. So I think my takeaway from that experience has been, as an independent research investigator, it can sometimes be hard to cultivate those relationships alone. Often it's better for us on the research side to identify a very strong, long running program of collaboration, start to develop relationships with people in that collaboration they are the ones who have the connection to the ministry. And then through that, sort of say, hey, I'm here. What are you guys working on? Here's what I'm working on. Have those conversations. It takes time. But ultimately, that is a more productive, in my experience, has been the most productive way to achieve that government sort of relationship.
Hmm. Hmm.
Can I have a question? Also, I like it. Congratulations again, but I think the idea was training people inside the universe there to start to develop projects to look this, and then this is a lot because I think it's just different, you have like a direct relationship with people from the government, but you can also have, as a scientist and professors, try to put this like bring the science there, the field there, and then maybe with other help them to produce papers, science there, and then the government maybe.
Yeah, that's a
I
good point.
Yeah, I think it just is very important what you have done there to training people.
I
And
think that was one of our good takeaways from Hamamet as well. A lot of the participants in the workshop, they were coming from hospitals and they were like, oh, well, we have this data too. Let's look at it for our country. And then we can, then they can publish it and share that with their governments. So there hopefully a lot of, collaborations, but a lot were interested, sometimes I think in research getting the data is the harder part, but they're like, we have the data and we want to do this with our data. So yeah, so Hari's expertise in these classes and knowing that they can, he offers this online, so they can go online. Finding the time is probably always the hardest part. Um, and learn how to do these things, and then they have our contact information to reach out to us for help and assistance. But yeah, then communicating that back to the governments, I think is always what we hope to do at the end of the day.
Dr. Diarra?
Thank you, and a very interesting presentation again. It would be interesting, and maybe you have the information already, to know how the trainees have applied, the skills that you have transferred to them over time. Because although I'm not an expert of, the topic, I would imagine that what you teach them helps them understand not only the genesis of the current situation or the limits or, limitations, sorry, or the barriers, but it can also help, planning for the future. And it can also help integrate, all actions, aiming at, diagnostics, treatment monitoring, addressing also the last mile issue, because sometimes, the center of excellence is there, but, patients don't necessarily have access to it. And sometimes you have a lot of goodwill, like, beyond government, beyond, Rutgers, many partners want to help, but if they don't have those geospatial, information, etc., they probably will shoot in the dark, or
Yeah.
it might be less optimal. So anyway, so I know it's a bit of a complex question, but in
Yeah.
the end, it's really to understand, the how do they apply the skills that you transfer.
Yeah, thanks for the question. And I admit that that is probably one of the limitations of the types of trainings that I've shared is um the follow-up. It's actually quite challenging when you have people coming just for one meeting and then all scattering and going elsewhere. The most successful collaborations that I've seen, it really doesn't just require the follow-up in the sense of just sending surveys or something, but ideally there's some on the ground presence. People are kind of coming back and forth. So, Western people are going, spending time in country, but also there's opportunities for scientists there to come to the West too. Because, yeah, I mean, it goes both ways. I mean, they can learn faster if they're here too. It's not just about us going there. And then it's always the who's paying for it is always the kind of thing. And I mean, I will say something that I have seen and that maybe is a good focus area is an health services is evergreen. I mean, there's always going to be somebody who will be ready to fund an innovative project on access to care and barriers, and of course in cancer. In that context, those are really important questions. Another area that's been growing, maybe less in the US right now, but in other parts of the world, is climate change. And so developing understanding what these impacts are, identifying vulnerable communities, developing resiliency factors. And these are things that a lot of colleagues in these places have to think of. I mean, they're confronted with this in the same way, and actually, in some ways, more acutely, because the resources are already limited. And so you get hammered by a flood or to extreme heat or one of these things. It's much more. It's almost more pressing. And there are, welcome trust is a big one in that space. There do seem to be some mechanisms that would support that, and I think it's a matter of finding that, like I was saying before, is there a group that through our network we have a good relationship with who could facilitate that, where there's people who are interested in this, and tacking on an educational component is never a problem. I think it's like you said, that the hard part is the sustained kind of infrastructure building, making sure that there's productivity, making sure that people are getting opportunities to advance their careers both here and there. That is always kind of those are things that are
Just
a little bit above my pay grade today,
quickly
but are
comment
things.
that I,
Yeah,
yeah,
please.
yeah, I just think that we are very good to apply grants because here NIH, you have NIH, and then maybe I work in Brazil, and then I a long time, and then I try to develop science there. So and then something they sometimes they have found being the question of Professor Armando is very important because maybe how you can follow up after the training. Maybe, try to say, oh, how you bring this to develop a project and then split that and then bring money to continuous. This is, I think, it's something that maybe you can help this, other countries to develop that. It's something that we know a lot here.
Yeah, and I would be very happy to kind of talk more about this with anybody here. I know Rutgers, sometimes we're all just kind of working in our own places, so it can be hard. But yeah, I'd be happy to talk more. Very interested in looking for ways to do this and to make sure that we're achieving those really kind of longer term impact kinds of goals through this.
I want to echo what Hari said earlier, for the support from the Rutgers Global Health Institute for supporting our workshop in Hammamet. It was a really great experience, and yeah, reminds me we should follow up with some of those connections that we made. And I think most of this follow-up will happen when we come to the next meeting and everyone is, we reconnect, and we'll learn about the work that they've been doing and how we can work together with them. But yeah, it was a great opportunity to be able to put on that workshop and share, the work that we're doing. So the geospatial like Hari said, it's a great area to be in. There's so many publicly available resources. There's a lot of information out there that can be compiled and used together that we can hopefully, help conquer this cancer burden with.
Well, thank you both so much for
Thank
the
you.
amazing presentations. Really exciting work. And yeah, thank you all for your attendance at a busy time of year. And yeah, Rick, any final words?
Oh, thank you. This is great that your collaborations and the focus on training the rest of us how to do this, and especially researchers and clinicians in Africa. And so just thank you guys for what you do.
Thank you. Thanks for the
Of course,
opportunity.
thank you.
Bye.
All right.
Bye.
Bye. Have a great
Bye.
day.
Thank you.
Thanks.